Bismillahirrahmanirrahim. Today's lecture is about a very important topic. The most important topic was DD, gradual loss of vision. Now, this is DD or differential diagnosis, sudden loss of vision. Sudden loss of vision, although it's not that common, but presents diagnostic challenges and requires urgent management. Now, what is the differential diagnosis of sudden loss of vision? The most important causes and beginning with the most common are venous occlusions, optic neuritis, wet age-related macular degeneration, retinal detachment, vitreous hemorrhage, CSCR, anterior ischemic optic neuropathy, and retinal artery occlusion. So first we will see the fundus photographs of these conditions, and then we will discuss the differential diagnosis. So what do you see in this picture? Very striking picture. Hemorrhages all around, hard and soft exudates, venous dilation, macular edema, disc edema. Remember this picture? Whenever there are hemorrhages on the retina with dilated veins, it is some type of a venous occlusion. Now these pictures. Another important cause of sudden loss of vision. You can see that there are discs in all three pictures. The disc, if you see closely, the disc margin is blurred. Whenever the disc is raised or swollen, the disc margin is blurred. Then you can see the color of the disc in these conditions. It is hyperemic, that is more congested. Veins, they are dilated and tortuous. There are hemorrhages and there are cotton wool spots. So this is what you call papillitis, and this occurs in optic neuritis. You can compare both discs in the lower picture. In the left picture, or you can say in the right eye, the picture is on the left side, the disc is normal, and for the left eye, you can see that the disc margins are blurred and there are few hemorrhages and the veins not that much dilated but are somewhat dilated. So this is optic neuritis. These are the signs. When we fit the signs with the history, we get to the diagnosis. If the diagnosis is a bit confusing, then we do investigations. Now look at this picture. What do you see? You see a hemorrhage in the center of the macula. In the big picture, you can see a small hemorrhage, and in the smaller picture, you can see a big hemorrhage with exudates. So another important finding you can see in the picture, on the bigger picture, is you can see that there are numerous small whitish dots scattered in the macula. These are drusen. So whenever you see drusen, whenever you see signs of age-related macular degeneration with a hemorrhage, then the diagnosis is wet age-related macular degeneration. This condition starts with a subretinal neovascular membrane, which then leaks and results in a hemorrhage in the subretinal area or even in the retina. So when it is in the subretinal area or in the sub-RPE area, it is blackish. When it is in the subretinal area, it is red. Another fundus picture, rather two pictures. What you see in these pictures is that there is a whitening of the, in the upper picture, bigger picture, you can see the whitening of the supratemporal retina with folds in the retina, whitish folds. This is called a corrugated appearance, and the retina is whitish due to edema. It is raised. So this is a typical picture of a superiotemporal retinal detachment. In the lower picture, you can see that the detached area extends from the superior to the inferior, temporal inferior half. So this is also another picture of retinal detachment. So the typical features are that the retina is grayish or whitish. There are folds, that is corrugated appearance. And another feature is that the vessels, the color differentiation is lost, and the veins and the arteries appear as of same color. Another picture of sudden loss of vision, the striking feature is that you cannot see the fundal details. Details are clear at places, and the details are blurred or invisible at some places. And the color is reddish. The thing that's obscuring the retina is reddish in color, and there is only one thing that obscures the retina in such a manner and which is reddish in color. It is hemorrhage, and the hemorrhage is in vitreous. Another striking or characteristic picture, one cannot forget once one sees this kind of patient, is this is a patient of a typical picture of a patient of central retinal artery occlusion. What are the features? You can see that the retina is whitish. All the posterior pole is whitish, and there is a central reddish area. This is called a cherry red spot. You can see the arteries that they are very narrowed in both pictures, and arteries are segmented. And this, although this is very rare, I have seen only about 5 to 6 patients in my entire career. But one should remember that this is this condition, although it is irreversible, the vision lost in that eye usually rather cannot be reversed. But the main thing is that this patient is at risk of dying from CVA or MI. So this patient should be diagnosed urgently, and then in addition to the management of the eye, he should be referred to a cardiovascular and a neurophysician. Another common cause of sudden loss of vision, although the vision is not greatly reduced in these patients, these are usually type A personality men of middle age, in which there is a sudden loss of vision, and when you see the fundus, you see a dome-shaped elevation of the posterior pole, like in the big picture, and you can realize, you can differentiate that there is an elevation by the reflexes, a whitish reflex around the base of the elevation. So in this condition, there is serous fluid collection between the neurosensory retina and the retinal pigment epithelium. This is central serous chorioretinopathy, CSCR. And lastly, this is a common feature, common finding, a common clinical presentation, common in the sense that it is common in the causes of sudden loss of vision. Otherwise, as I have previously stated, sudden loss of vision is quite not that common, but the patients usually come. And the striking feature in this picture is that the disc, you can see the disc in this picture, the disc is swollen. You can see that the disc is swollen because the margins are blurred. And if you see the color is very striking. If you compare it with optic neuritis, in optic neuritis, there was the same picture. The veins were dilated, there were hemorrhages, a few hemorrhages, and the disc was swollen, but the color is different. And in that optic neuritis or papillitis, the disc was congested, more red in color. And in this, there is pallor. So this condition is anterior ischemic optic neuropathy. Now we can see, or we can give the differential diagnosis of sudden loss of vision in a tabulated form. So first of all, history. In venous occlusion, there is a history of diabetes mellitus, hypertension, glaucoma, and the patients are of old age. In optic neuritis, the patients are young. There is a history of pain in and around the orbit and also on movement of the eye. There is disturbance in color vision, and the patient says that the light, it looks like that the light has been turned down in his vision. In the left eye, you can see bright images, and in the left eye, the images are very dull. And there may be a history of multiple sclerosis. In wet age-related macular degeneration, typically the patient is of advanced age, and the patient presents with sudden loss of vision and distortion of vision. Initially there is distortion, and then there is a central scotoma. In a retinal detachment, the patient typically, if he is a young patient, may give history of trauma, or he may be a high myope. And in elderly patients, there is a history of trauma, or there is a history of surgery, complicated cataract surgery. And the patient complains that initially there is a shower of black spots, and then there is a curtain-like, like there is a curtain which is drawn from above downwards. In vitreous hemorrhage, typically there is a history of diabetes mellitus or central retinal venous occlusion, or there is a history of trauma. The patients there may be a history of diabetes. The patient initially complains of floaters, blackish floaters, which then suddenly there is marked decreased vision. In central retinal artery occlusion, there is a typical, the patients typically have heart disease. They may give history of amaurosis fugax. This is loss of vision for a few seconds off and on. And patients are usually middle-aged to elderly and have diabetes and hypertension. In CSCR, as I previously stated, that the patient is male, middle-aged, type A personality, and he complains of sudden loss of central vision, in which there is distortion. The images seem to be of smaller size. They may be distorted, and there is as the retina is pushed forward, there is a hypermetropic shift in his refraction. In anterior ischemic optic neuropathy, there is a history. The patient is of middle to old age, history of cardiovascular disease, in a special type of separate and a special type of anterior ischemic optic neuropathy that is due to giant cell arteritis. There is a history of constitutional symptoms, proximal weakness, fever, jaw claudication, pain in the temples, and typically there is a sudden loss of vision, which may be moderate to severe, and the patient gives history of uh, visual field defect which is altitudinal, that is upper half or a lower half of the field is damaged, is defective. So this is history, and then we go to the age. Venous occlusions occur in elderly, 60 plus. Optic neuritis usually in young individuals, females. Wet ARMD as the name suggests, in old age, 60, 70 plus. Retinal detachment any age. Usually we see patients, previously we used to see patients that were elderly after cataract surgery, and this was a very, not a common, but it was an important complication when we did intracapsular cataract extractions, in which the vitreous, there was no barrier to the vitreous prolapsing into the anterior chamber. And when the vitreous prolapsed into the anterior chamber, it caused pull on the retina, which resulted in tears and retinal detachment. In vitreous hemorrhage, there is also no age prediction, prediction, and usually the patients are middle-aged, but trauma patients can be of any age. Retinal artery occlusion, middle-aged, usually middle to old-aged, and central serous chorioretinopathy patients are usually middle-aged. Anterior ischemic optic neuropathy are middle to old-aged. Then, how much the vision is reduced in each of these conditions? In venous occlusions, it is moderate to severely reduced. In optic neuritis, same, moderate to severe. Wet AMD, there is a central defect. Peripheral vision is okay. Patient can walk around and do his normal routines, but he has a big central scotoma. In retinal detachment, depends on how much retina is detached, and the area which is detached is there is a visual field defect in that area. Vitreous hemorrhage, the vision is usually severely reduced. And retinal artery occlusion, the vision is severely reduced rather than there is no PL. Usually the patients with central retinal artery occlusion have no PL. That is, the eye is blind. Central serous chorioretinopathy, in this condition there is mild to moderate visual loss. In anterior ischemic optic neuropathy, there is moderate to severe visual loss, but it is altitudinal, either lower half or upper half. Now the pupils, very important sign in diagnosing cases of sudden loss of vision. Venous occlusions, if it is a branch venous occlusion, then the pupils are usually normal, but in central there is RAPD. In optic neuritis, mild or moderate, the only sign, sometimes it is the only sign, the pupils, and there is the sign is present in the pupil is that there is a RAPD, relative afferent pupillary defect. In wet ARMD, it is normal retinal detachment unless it is total and severe. It is normal. Vitreous hemorrhage, it is normal. In retinal artery occlusions, it is the pupil is severely affected as the patient is blind. So this pupil is APD, afferent pupillary defect. It doesn't react on direct, but on consensual it reacts. And in central serous chorioretinopathy, the pupils are normal. In anterior ischemic optic neuropathy, the pupils are always abnormal. That is, there is a relative afferent pupillary defect. Vitreous is normal in all cases except in retinal detachment. There may be vitreous opacities, there may be tobacco dust, and the vitreous there is blood in the vitreous in vitreous hemorrhage. In other conditions, the vitreous is usually normal. But in conditions with disc edema, there are usually some vitreous there are cells or there are inflammatory cells in the vitreous adjacent to the optic disc. Now coming to the disc, very important, the disc. In venous occlusions, in mild occlusions, in branch venous occlusions, there is no edema, but otherwise there is edema. Optic neuritis, there is edema, obviously. In age-related macular degeneration, wet, the disc is normal. Retinal detachment, the disc is normal. Vitreous hemorrhage, if one can see the disc, it is normal, but can have neovascularization. In retinal artery occlusion, the disc is normal. Central serous chorioretinopathy, the disc is normal. And in anterior ischemic optic neuropathy, the disc is edematous, but it is pale. So there is edema in three conditions: in venous occlusions, optic neuritis, and anterior ischemic optic neuropathy. We can differentiate optic neuritis with anterior ischemic optic neuropathy by the color, and we can differentiate these two with venous occlusions by the fact that the whole of the retina or the segment that has been occluded has multiple hemorrhages and cotton wool spots. Now coming to the macula and the retina, venous occlusions, there are hemorrhages of all types, flame-shaped hemorrhages, dot blot hemorrhages, lots of hemorrhages, edema, hard exudates, soft exudates, cotton wool spots, venous dilation. So this is a very typical picture. In central venous occlusion, there is a term is used is a bucket full of blood. So when you see the fundus, you see blood everywhere on the retina. So this is an easy diagnosis. Whenever you see a fundus picture which has blood all around, and there are exudates and hemorrhages and veins, and you can then focus on the veins. The veins are dilated, tortuous. Then you focus on the disc margins are blurred. You can safely say that this is a case of venous occlusion. Optic neuritis, if it is retrobulbar, all the things are normal. If it is papillitis, then the disc is edematous, congested, veins passing through the disc are dilated, and there are few hemorrhages. But the important sign here is that there is RAPD. Even if there is retrobulbar neuritis, that is the part of the optic nerve which is behind the optic disc is inflamed, even then there is RAPD. So there is a saying one should remember for these kinds of patients, that the patient sees nothing, that the patient is blind, and the doctor sees nothing, that there are no signs present in the eye. Eye looks quite normal, except the fact that there is a relative afferent pupillary defect. In wet ARMD, one can see a grayish green membrane if we see the patient initially in the macula. Then there is hemorrhage. If the hemorrhage is subretinal, it is dark in color. If the hemorrhage is in the retina, then it is red in color. And it is also associated with hard exudates and edema. Retinal detachment, as I've told you, that there is elevation of the retina. The retina is grayish or whitish. It has folds, corrugated appearance. Veins and arteries are of similar color. And it is a very typical presentation. Once you see it, you cannot forget it. Vitreous hemorrhage, very typical. If you see all the media are clear, that is, cornea is clear, there is no reaction in the anterior chamber, lens is clear, but you cannot see the fundus. If this is the case, then it is vitreous hemorrhage. Retinal artery occlusion, another typical picture. Very rare, but one should know because of its life-threatening implications. So what you see in the fundus is a whitish posterior pole with a central red dot. This is called cherry red spot. The arteries are very narrow, maybe segmented, and the patient vision is greatly reduced. Patient is blind. Then there is APD, not RAPD, but APD. APD means that pupil is not reacting to direct light, but consensually it will react. So it is a very typical picture. You can differentiate both of these occlusions by just a glance. If you see the fundus in retinal artery occlusion, whenever you occlude an artery in everywhere in the body, in the limb, the distal area becomes white, pale. So that's why the retina is white, pale in retinal artery occlusion. And whenever you block a vein in any part, that part becomes swollen and bluish and reddish. So the same happens in the retina. Whenever the vein is occluded, the vessels leak and there are hemorrhages and veins are dilated. So the students confuse these two clinical entities in the exam. It's very simple. In arterial occlusion, there is ischemia. Whenever there is ischemia, there is pallor. And in venous occlusions, there is blockage of veins which dilate with dilated veins, which then leak and lead to formation of hemorrhages. So in central serous chorioretinopathy, what you see is a rounded elevation in the posterior pole, and the rounded elevation is surrounded by a grayish halo, and the fluid. The elevation is due to the collection of serous fluid in between neurosensory retina and the retinal pigment epithelium, and this fluid is usually clear. And this is also a typical picture. Once you see it, you never tend to forget it. And then lastly, anterior ischemic optic neuropathy. It is a picture very similar. It has a picture very similar to optic neuritis or papillitis. But the main differentiating point here is that the disc is pale. Because why it is pale? The short ciliary arteries have become occluded due to old age, due to hypertension, diabetes, or due to inflammation due to giant cell arteritis, or due to it may be the occlusion may be due to connective tissue disorders. So very easy to differentiate. The similar things are optic neuritis and anterior ischemic optic neuropathy, but we can differentiate them with color and with the visual field defects. The optic neuritis produces a central defect, whereas anterior ischemic optic neuropathy produces an altitudinal defect. So with this we come to the end of this lecture, and I hope you will be able to differentiate various causes of sudden loss of vision with the help of this lecture. Thank you.